So today is Tuesday. Just a minute. Yes, happy Diwali to everyone. All right, now it's fine. So today is Tuesday, right? So we are meeting today. Day after tomorrow there is Diwali. So as everyone said, right? We are meeting on Diwali. Is it fine? Or you want to take a break? It's fine, fine. Yes, it's fine. No, what I'm telling is, say, so most 90% are fine. All right, we meet. Right? So 5:30, right? Day after tomorrow. On Saturday we can keep it off. Right? On Saturday we can keep it off, and then we'll resume for the next week. Okay. So let's start for today's topic. And today we'll be talking about congenital heart disease. Now, what you will be learning in this is, in congenital heart disease, it is not so that we'll where to meet here only. Here only. So, in congenital heart disease, we'll not be learning only the disease. We'll be learning the diagnosis. We'll be learning the sign symptoms. We'll also be learning about its X-rays, CT scan. Everything is going to come today. Then color Doppler, right, and 2D echo. So all these things, and you'll find that it is not that complicated. You'll be able to understand everything very crisply. So let's start. So congenital heart disease, when we say this is like part 1, yes, there would be second part also. And we have divided it into this two things. One, this is today's part, acyanotic. Acyanotic means when you see that baby who has got the congenital heart disease. Congenital heart disease means there is something wrong in the heart of that baby. Something is wrong. Right? So that baby would be a pink baby. That means that baby is not blue, it's pink. Volume or pressure load overload will be there. And ASD, VSD, PDA, and coarctation of aorta. These are the four things. ASD means atrial septal defect. We'll be discussing all the conditions in complete detail. So atrial septal defect, ventricular septal defect, patent ductus arteriosus, and coarctation of aorta. What is expected from you is that you should be understanding the embryology very properly. And we have spent enough time on that. Correct? Though we'll be touching it briefly when we'll be discussing any of the specific condition. Color of the healthy baby, it is pink, right? Normally it is pink only. But this second condition, which is more dangerous, cyanotic, when the baby turns blue. And that's the reason that in case of cyanotic, most of the babies, they die, right? Especially say there would be tetralogy of Fallot, or transposition of great vessels, tricuspid atresia, truncus arteriosus, hypoplasia left heart syndrome. All these are very fatal conditions, right? And you require immediate diagnosis, and you need to take the action immediately. Else, you have got only very limited time. While in these cases, things are not that bad, and it is easy to diagnose. That's the reason that today we'll be discussing the acyanotic part and all these four conditions. When we'll be discussing these, you have to remember just two things in mind. Same, whatever you have learned till this point of time in the form of respiratory system. Right? In respiratory system, we talked lots and lots about pulmonary congestion. What is pulmonary congestion? That is when the amount of blood is pooled into those lungs, right? मतलब lungs में blood रुक गया है. There is overload of blood into the lungs. That is one. Second, when it comes to heart, when it comes to cardiology, this time we have to understand all the four chambers separately, right? We have to understand all the four chambers separately, because in some of the conditions, right atrium would be enlarged. In some of the conditions, left atrium would be enlarged. Now, you are smart enough, you know that if this is the heart, right? If this is the heart, this is the normal heart. Which chamber is where? Well, you know this part, that if this is the right, this is the left, so then we draw it like this, correct? This one is right atrium. The right ventricle is right in front. So that's why if we really want to see the right ventricle enlargement, we have to see the lateral X-ray. We have to watch it from the side. So then and then we have seen all these X-rays, right? Though as the conditions would come, you'll be able to see it. Then this one is the left ventricle, right? Which is making the left side of the heart. And where is left atrium? Behind, right? It is on the back side. All these things. Remember this image. You must have drawn it dozens of times. But when we say this is anterior, so that means anterior is always right ventricle. Right? On the right side, this is the right side. We have got the right atrium. This one is the left atrium, which is behind. And what would be over here? That would be the esophagus. That's why when the left atrium is enlarged, it will compress the esophagus. And that's where one would be getting dysphagia, difficulty in swallowing, because it is compressed by the left atrial enlargement. And obviously this one is the left ventricle, this is our left side. This much picture should be crystal clear into your mind. The rest of the things, as it will follow, you'll be able to understand it. Right? So here it is, this is the acyanotic part. Now, when we say congenital heart disease, what can really go wrong in the heart? Well, it can be some defect in the structure. Right? Some structure has not formed, or some structure has overformed, right? But there is some defect in the structure. Second, function of the heart. Some structure is not functioning properly. Structure-wise, it is okay, but it is not functioning properly, especially when we see that when it comes to our SE node or AV node, right? So they are not functioning properly. Or the vessels, blood vessels, there are major blood vessels coming out. They are obstructed, right? If they are narrowed, so then obviously if the path is narrowed, then it will be creating a back pressure. So the chamber from which that artery is going out, that would be compressed, right? So that artery is compressed, so that chamber would be enlarged, back pressure. Or the abnormal path. This would be very interesting when we'll see that instead of, say for example, when we say transposition of great vessels, we'll be understanding it in amazing detail when we'll be discussing this TGV, transposition of great vessels. When we say that from right ventricle, what comes out? Pulmonary trunk, right? What if aorta comes out of it? We talked about it briefly when we were discussing the embryology. From left ventricle, aorta comes out. What if the pulmonary trunk is coming out? Right? This is complete chaos, right? But this is what is called as the abnormal path. Right? So thus, we'll be understanding all the conditions, practically speaking, not only that we'll be understanding only the atrial septal defect, or the ventricular septal defect, will be going into the detail of the types of ASD and VSD because it will make your embryology super strong. At the same time, now you will be watching X-rays. Then today we'll be understanding the basic principle of color Doppler, right? We'll be understanding 2D echo. We'll be understanding CT scan. We'll be understanding MRI. We'll be understanding angiography. Because all these things, they are done for a diagnosis, right? So that's why. And when you'll see, you'll find it that yes, it is not that difficult if your embryology is good, right? Chalo, let's start with, and these are the third one is the vascular malformation. This will take at the end, right? After we complete the cyanotic, then we'll take it in the next lecture. So right now, don't worry about it. These are some vascular tumors and AV malformation, arteriovenous malformation. So very interesting topics. So let's start with ASD, atrial septal defect. Right? Now, in embryology, say if we just draw this part, right? So here is the right atrium and the left atrium, and we are talking about this. That is the interatrial septum. Whenever there is hole in it, right, it is called as the atrial septal defect. There is hole, right? When people say that there is hole in the heart, commonest is this. There can be over here. This would be the ventricle, so there can be hole into the ventricular septum also, right? But currently, right now, we are focusing on this. To understand it much better, we go through at a very high speed how this interatrial septum develops. There were few terminologies. Right? So first one is the septum, right? Septum starts. It is primum, septum primum. Right? Now this is like a continuous journey. Here starts the septum primum. Here starts the septum primum, right? As it goes, right, it happens like from the top portion, right, it starts disintegrating, and then all the way it will touch this part, correct? So literally from the top it started coming down. Now this is very loose, right? It can move easily. So this is loose, right? It can flow easily. Then starts the septum secundum. So that septum secundum, it develops. It is rooted to the top wall, right? It won't be disconnected. And there we find that this one is our foramen ovale, right? So much you know. Foramen ovale. So this is septum secundum, and this one is the septum primum. At birth, when the pressure in the left atrium, when the right atrial pressure will drop, so left atrial pressure will try to send the blood from this path, but because this is loose, the pressure would be generated and it will snugly attach with it, and thus it will fuse and it will form the fossa ovalis, right? So this is what really happens in case of the development of the interatrial septum. So keywords are septum primum and the septum secundum. When we say ostium means this is nothing but it is that space, right? Okay. Now what happens is, here it is. For some reason, these are all the keywords are there, right? All the keywords. Here it is the left atrium, here it is the right atrium, right? Just focus only on this much, where the pressure is more. Pressure is more after birth, right? After birth. So after birth, from right atrium, blood goes to right ventricle. From right ventricle, it is comfortably going into the lungs. So all the pressure has been relieved, right? So blood is going smoothly. While left atrium, that is going on to the left ventricle, it is going all the way to the aorta. So pressure is high because this is a systemic circulation, so pressure is high. If we have a hole in the interatrial septum in our patient, what would happen? The blood would be going from high pressure to low pressure. That means it will start going in this direction, because this is our systemic circulation and this is our pulmonary circulation. Pulmonary circulation is always at a low pressure. So that means things will be moving from high pressure system to low pressure system. That's where the first thing which is said is that this is left to right shunt, right? And this is the most common anomaly, which is seen in case of, say, kids. The next point, this leads to pulmonary congestion. This way, the extra blood which is going from left atrium to right atrium, it will go to the tricuspid wall. From tricuspid wall, it will go to the right ventricle. From right ventricle, it will go to lungs. Extra blood is getting pushed into the lungs. Extra blood is getting pushed into the lungs, right? And that also with force, because it is the force of left atrium. Systemic circulation's power that is behind. It presses right atrium all the way right ventricle to the lungs, and that's how this will lead to pulmonary congestion. Make sense? Right. So it leads to what is called as the pulmonary congestion. More blood is collected over here. So this is pulmonary congestion. Things to understand is the types. Now, as you know the anatomy and the embryology, see how easy it is. The first one, the primum ASD. Primum ASD. Primum means septum primum we are talking about. So septum primum is at fault. Simply, this is what has really happened in this case. The septum primum, right? And now I'm removing this. So septum primum, which was supposed to go all the way down, all the way down, all the way down, and all the way down, it should have met that endocardial cushions over here. Something happens and it stops its journey in between. That's it. Right? In between. So right atrium and left atrium, right, it has formed. This is a gap. This is a gap. Right? So it from the posterior wall, it went all the way. Think it like that we have, right? This is the chamber, right? So the wall started developing all the way over here. It should have developed like this, but instead of that, it has developed only like this. This below portion is left out, right? So that is what is called as the primum ASD. So in primum ASD, which is also called as the low ASD. Okay? Makes sense, because it is low. It is always over here. So this one is the primum ASD. Same way, secondum ASD. What secondum ASD would be? Secondum ASD can occur in two ways. One, this septum secundum, its duty was to develop so that it should overlap the septum primum. then after birth, right, it would close. What if it develops only this much? Right? If it develops only this much, this foramen, right, till the baby is in womb, nothing would happen, because that is the foramen ovale. In any case, it was to be kept open, and it is open, right? But after birth, when it was supposed to close immediately on the first cry, it won't. It won't, because the septum secundum, that is small. So this is the second part, septum secundum. Correct. And it is more common in 70% of the cases. And I'll show you actual cases, right? Not one, but many. The third, which is usually confusing, and this is called as the sinus venosus ASD. This is in 10% near SVC or IVC. In order to understand this thing, we need to go, we need to draw, we need to draw something. Let's draw it here. Here is the right atrium, and here is the right ventricle, and this one is the left atrium. We are talking about this, correct? Interatrial septum. So what I'm telling you is, what if we remove this wall? If we remove this wall and we watch it from here, so we are sitting into the right atrium and we are watching. Now in right atrium, right? Now see this. This is the right atrium, right? This one is right atrium. Why I'm telling this is right atrium? Because it's very easy from top and from below. This is the inferior vena cava and this is the superior vena cava which are entering, right? So which wall would be this? Which wall? Because this is the right ventricle. This is the right ventricle. So this must be the tricuspid wall, right? And from tricuspid wall, the blood is going like this. And from right ventricle, it is going and it is going into the pulmonary trunk and it is getting distributed to both the lungs, right? So far, so good. Okay. Now, can you, I'm just drawing this line. This is like tricuspid closed. Where is, if this is the right ventricle, this would be the left ventricle, because see the thickness of the wall. Where is the left atrium? Where is the left atrium? Left atrium is just behind. And in left atrium, from left atrium, right? If this is the left, this is the left atrium. What are the inputs of left atrium? What enters into left atrium? Are you with me? What enters into left atrium? We are 47. What enters into left atrium? Pulmonary vein. That's right. That's right. Right. So they enter. Pulmonary trunk, nahi mere dost. Pulmonary trunk, so it goes out from right ventricle. I'll not take the name, right? Those who have written, because there are 4%. Understand this. Understand this. This is pulmonary trunk. That's okay. Oxygenated trunk. That's fine. Right? Got it? This is pulmonary trunk. So this is the right ventricle. From pulmonary trunk, it will be going on to the lungs for oxygenation. This is carbon dioxide, right? Deoxygenated blood. And that blood, where it will get the oxygen and then it will enter via, these are the pulmonary veins, right? Pulmonary veins, they'll be carrying the oxygenated blood and they'll be landing into the left atrium, and left atrium is behind. So that's why we'll not be able to see this thing. That's why over here, these are the dotted lines. Right? These are the dotted lines. So that chamber is behind. So the wall which you are watching over here, this is the, in fact, interatrial septum. Now clear, right? This is the interatrial septum. So if we really see that wall which is behind, right? So let's make, say this is the left atrium. You know? If this is the left atrium, so then this would be our septum secundum, and this one would be our septum primum. Clear, right? And then this is what we are watching is the AST, atrial septal defect. Right? This is a drawing just for the understanding. Right? So now we are clear about that. If this is the septum primum, this one is the septum secundum, this is how it occurs. When the gap is over here, this is near superior vena cava. When the gap is over here, it is near the inferior vena cava, because the image, right? This is the image. But as I said, that if we really draw, if we really see it like this from this perspective, right? Classically, it will look like this. Classically, it will look like this. This is right? So this is the left atrium. This one is the right atrium, right? And I'll hide, and this is the septum, which is between both of them. Clear, right? So when we said the septum, when we say the septum primum problem, right? Septum primum, that is the primum ASD, this one. So then the trouble was here, right? The hole was here. Because that septum, in fact, this entire thing is septum, right? So this entire thing is septum. But it failed to develop in this much region, so this was our first. When the septum secundum was not developing, so then it led to that, right? It was over here. So this is the second type, septum secundum type, right? So this one is the commonest one. Now in right atrium, it is over here and over here. It is the superior vena cava, and over here it is the inferior vena cava. Sometimes it happens that there is gap between in this septum at a very high level or at a very low level. So it is the gap which is over here. This one. Or the gap is over here. Because see, this is the chamber. This is the right atrium. From top superior vena cava. From here inferior vena cava. But just behind, right, there is right atrium. So that gap is over there. Possible, huh? Why not? Because the chamber is like this, right? So these are the, and then this is the right atrium, and then over here on the back side, this is left atrium. So this entire thing is wall. So that's why when the hole is over here, when the gap is over here, right? So that is the near superior vena cava. When the gap is over here, it is called as the inferior vena cava, right? Gap is near inferior vena cava. When the septum itself, right, it is over here, this is the septum primum problem. When the gap is over here, then this is septum secundum problem. Because septum secundum, that would be right in the center. That foramen ovale, that is no way it can close. So thus we have got four types. One, primum ASD, secundum ASD, which is 70% most common, and we'll be watching these cases. Sinus venosus ASD, because from sinus venosus, right, there is development of superior vena cava and inferior vena. When there is ASD, so when the gap is over there, then it is in about 10% of the cases, and in very rare cases. What happens because of the gaps? And that's what we are discussing. That gap itself is now called as the ASD. In other words, what we have learned is that whatever the way there is gap, right, between left atrium and right atrium wall, right, interatrial septum, that thing is called as the AST, atrial septal defect. Now, what would happen? We'll see. This is a rare thing. Common atrium. Common atrium means what? In some of the cases, neither septum primum develops nor septum secundum develops. Right? So literally, no primum, no secundum. So here, it would be just like this. Just like this. This is what is called as the common atrium. Right? Nothing. The full gap. Right? Now, this is dangerous. Correct? Because there is no pressure control. Everything is safe. So that is what is called as common atrium. This is rare. It is seen more in case of females as compared to males. Right? Like heart of fish. Yeah, like heart of fish, heart of frog, right? Three chambers. But over here, there is a trouble. Because superior vena cava and inferior vena cava, they will be coming over here, and pulmonary veins, they will be coming over here. So both the bloods will keep on mixing. Right? So body will keep on moving into the form of a mixed blood only. There will never ever be pure oxygenated blood. That's why such babies, they don't survive. Yes, we'll talk about the treatment. Aditya, just hang on a while, right? Just we see the things and then we'll discuss about it. So here is the first we learn the hemodynamics. Hemodynamics means what would really happen when the patient is having this type of problem. So initially ASD allows a left to right shunt. We understand that, right? Because from the left atrium, the pressure is more. This is the right atrium. So that's why the blood would be pushed from left side to right side. Oxygenated blood, yes, this is oxygenated blood. And over here, this is the deoxygenated blood because there is more carbon dioxide. Oxygenated blood from pulmonary veins, right? Because over here, the pulmonary veins were entering. Right? This is because of genetics. This is because of genetics. Right? It's more common in females. So, left atrium, this is where the pulmonary veins, right, they are landing, and that oxygenated blood is getting pushed into the right atrium. So when the right atrium is getting more blood, right, it is getting extra blood, it is getting extra load. So that will lead to the right atrial dilatation. Right atria would dilate because it was expected that only supra vena cava and infra vena cava they will drain the blood. Now this left atrium, so it is bindas, it is pushing the blood into the high velocity at the same time with more power, right? So right atrium enlargement. Right atrium will push the blood to right ventricle. Yes, so right ventricle would also be enlarged, correct? When right ventricle is enlarged, right ventricle will try to push that blood into the pulmonary trunk. From pulmonary trunk, it is the right and left pulmonary arteries, correct? Pulmonary arteries, pulmonary artery, right and left. Pulmonary trunk is a thick structure. It's a powerful structure because it is formed from the same tube as that of aorta, right? Because it was a common tube, right? Truncus arteriosus, and then the septum develops and then the whole thing rotates. But when it comes to pulmonary artery, they were supposed to enter into the lungs, low pressure, right? Now when the pressure is increased all the way, right? This is a high pressure which is generated, high pressure. That high pressure will be reflected onto the pulmonary artery. So thus there will be pulmonary artery dilatation. That is the reason right atrium, the right ventricle, and the pulmonary artery dilatation. And then what happens over here? Lung tissues. These are the lungs. And then there would be the pulmonary congestion. The blood would be pooled over here. It won't be able to clear so much of blood fast. So that's why blood would be pooled. Right? More blood comes, then blood goes further. So there will be the pulmonary congestion. Achha. This is one of such thing. If you understand it in 1 minute. Right? So just focus. Here it is. This is left atrium. This is right atrium. I'll not say this is the most complex thing, but this is the thing which you have to visualize. Once you visualize, you'll find that it is very easy. Left atrium, right? The blood is going over here. Left atrium to right atrium to right ventricle to lungs. Now, when you keep on pushing the blood, into the lungs, what would happen? We learned what is called as the pulmonary hypertension. Right? There would be increase in the blood pressure, right? There are two blood pressures. One is the pulmonary blood pressure and second is the systemic blood pressure. What we measure, right? So that is the systemic blood pressure, 120 by 18 millimeter of mercury, systolic, diastolic. But the pressure which is into the lungs, that is now rising. So this is the pulmonary pressure. Pulmonary pressure. This pulmonary pressure will start rising. So that is what is called as the pulmonary hypertension. When the pulmonary hypertension, now this pressure keeps on rising because blood is getting pooled, right? And the capillaries and everything is delicate. They can't move fast. So it takes time. This doesn't occur immediately, but it takes time. Gradually, the pressure is mounting. And then one day, there is pulmonary vascular obstruction. Right? There is so much of collection of blood that it is unable to move further. Right? The inflow is much more as compared to the outflow. Now, when this thing occurs, it will start generating the back pressure. Right? It will start generating the back pressure. So here, this is the lung. Now the pressure is so much that this right ventricle, it is trying to push, but it is getting so much of resistance. So this starts generating back pressure. Right? Right ventricle, that back pressure would be generated to right atrium. And one day, when the right atrial pressure is more than left atrial pressure, I mean, there is so much of congestion that even if left atrium tries to push the blood, it cannot move because the lungs, they are loaded, right? So this is the point when there is pulmonary hypertension, and so many complications would have started, right? There is right to left shunt. Right to left shunt. The blood, instead of going from this side to this side, it now goes to this side because right atrial pressure is more. And that is what is called as right to left shunt. It is called as the systemic desaturation. Systemic desaturation. That is, now there is no possibility that blood can be pushed into the lungs, and that leads to cyanosis because this is the deoxygenated blood. The deoxygenated blood is getting pushed into the left atrium, right? So over here, it is the mixed blood. It is that mixed blood which is going into the circulation. And this thing is called as the Eisenmenger reaction. And I'll show you a method how to see that thing. You just see the X-ray and immediately you say that condition is worsening. Though on X-ray it would look much better, right? The congestion has decreased. Of course, that congestion has not decreased. It is Eisenmenger which has started, right? So we'll see that case. We'll see. So think it like when the ASD develops, initially there is no Eisenmenger, right? Because lungs, they have got capacity. Right? Lungs will keep on holding, they'll keep on rising, right? But at one point when the limit comes, then lungs, they say, okay, bas baat khatam, right? Now they are rising the pressure, and that pressure has increased so much that the blood moves from right side to left side, and this thing is called as the reversal of shunt, right? Reversal of shunt. We learned about the reversal of shunt in one more area. And if you remember that just after the birth, when the patent, when the ductus arteriosus has not yet closed, right? Placenta has been removed. So placenta is removed, so there are no prostaglandins. So that ductus arteriosus is open. Correct? Ductus arteriosus is open. Ductus arteriosus is the connectivity between the pulmonary trunk and the aorta. So now the pressure in the aorta is more. So till this point of time, what was happening? Because the lungs, they were all blocked. They were into the amniotic fluid. So that's why the blood was flowing from pulmonary trunk to aorta. But now the aorta is more powerful. So that's why the blood will be flowing from aorta to pulmonary trunk for some time. Right? This is normal. This is normal. Because very soon this ductus arteriosus will get fibrosed, will get closed, and this reversal of shunt stops. Nothing happened. Right? No problem to the baby because this is normal. It happens within 1 or 2 days. And all is good. But over here, this thing is dangerous. Right? This is what is called as reversal of shunt, in which from right side, the blood is pushed into left side, and that leads to cyanosis. That is, though this is a acyanotic condition. Acyanotic means atrial septal defect initially, right? Baby is not turning blue, but when Eisenmenger reaction occurs, baby starts turning blue, cyanosis. Baby becomes blue. So complications of Eisenmenger reaction eventually occur. So this is the point from where the complications will start. Right? We'll see that. What are the complications? So initially, when the ASD, right? These are the ASD, atrial septal defect. Now, any type of atrial septal defect. Right? Because what type of atrial septal defect is, that is when we'll diagnose. But when it is there, So then we know that this will be moved from left atrium to right atrium, right? Blood is going. I think Sonam, that actress, she is having atrial septal defect, but the size of the atrial septal defect is so small that it won't matter much. But still, you'll find that when such things happen, this is one important thing. Failure to thrive. Thrive means growth, right? Their growth is either stunted or it becomes slow, right? The physical growth, because the muscles, right, they will be requiring. The muscles, they will be requiring much blood. So here, their growth is decreased. So frequent symptoms in patients with a large ASD. This happens with a large ASD, right? Small ASD, so many times people don't even notice. Right? And if it is very small, so then you might say that, okay, let it remain as it is. Nothing is to be done. If it is large, so then there is fatigue. Makes sense? Because the good blood, the oxygenated blood is going towards the right side. So again, that oxygenated blood will be going into the lungs for no use. It is already having large amount of oxygen, but the body is not getting. So this is fatigue, lack of oxygen. How will you really know this thing? That baby, when he is lactating, right, when he is drinking milk, right, gasping, right, that baby, you'll find that baby will be gasping, right, that way, right. Then there will be frequent upper respiratory infection, right? Upper respiratory infection. This is because of congestion, right? Because of congestion. When the blood is pooled anywhere, when the blood is pooled, so it will lead to that infection. Stunted growth we talked about. And then there will be dyspnea, breathlessness. Dyspnea is breathlessness, correct? So there will be breathlessness on exertion. On exertion, normal activities, they are not affected. But when the baby tries to run, right, tries to walk, you will find that he'll sit down, right? Or all the landmarks, they are slow. Right? Baby will not start walking by the age of even 9 months, 10 months, right? Still falling. So there will be breathlessness on exertion. But when Eisenmenger reaction occurs, this is what really happens. Patient develops, first thing is cyanosis. Right? Because now the blood, the shunt has moved from right to left, right? At a point, can there be like 100% congestion? 100% of congestion never occurs, because as such, from lungs, the bronchovascular circulation is already there. Now, so some amount of blood will always be going further. Right? Some amount of blood will always be going. But when the gap is big enough, so there is so much blood is coming, but some blood will always be leaving the lungs and going on to the left atrium, right? Onto the left atrium. So 100% congestion can never occur. But yes, if the congestion is more, so it will generate the back pressure. That's the problem. Okay. Fatigue makes sense. And exercise intolerance. Up to over here, it was the dyspnea on exertion, right? When baby tries to run, yes, will be breathless. But over here, exercise intolerance means unable to do any of the exercise. So complications of Eisenmenger reaction. One is the cyanosis, right? Baby turns blue. Second, the stroke. The stroke occurs because, say, in case of ASD, it's a very complicated thing, but just remember, in case of ASD, the patient is having, because it is a genetic thing. So patient is having polycythemia. Polycythemia means there is, if you really go for CBC, right, you'll find that their RBC count is very high. There are more RBC. Because it is body's natural reaction. Body will feel, say for example, if you go to, I'll just discuss, no problem. If you go to height, right? Say for example, many of the marathon runners, they go to Kenya, right? They go to Kenya, and when they reach over there, because it is at height, so now the oxygen pressure is less, and when they exercise it over there, so they develop extra strength. There is erythropoiesis. There is more formation of RBCs, right? They carry more oxygen because the oxygen is less. So that's how body improves its efficiency. Same thing happens over here, but here blood is not improper. Pressure is not. Everything is fine, but still body feels my tissues are not getting sufficient oxygen. Increase the blood, right? So that RBCs they increase. When the number of RBCs increase, so that leads to formation of clot. And when that clot, it lodges into the brain, it leads to stroke. When it lodges into any of the other area, so it leads to failure of that particular organ. Can it be identified with stethoscope by the sound? We'll see that. I'll show you. Right? Just hang on. Right. So this leads to, because now the right atrium and the right ventricle, they are enlarged. So chances of right heart failure, so collectively they are called as the right heart failure, that becomes very high. Another thing is right atrium. SA node was where? SA node was just at the root of the superior vena cava, where the superior vena cava enters. Right? So when we view it over here, this is the location of SA node. When this right atrium is affected, so that SA node, that also, and then there is Bachmann's bundle, which is supplying to the left atrium, right? And then there are fibers which are supplying to the right atrium, and then there is SA node to AV node. But the trouble is, when this right atrium is affected, it starts affecting even this electrical system. And that is what leads to atrial fibrillation. So atrial, this is a normal beat, right? This is how the heart beats normally. Fibrillation is like this. And still worse is flutter. Flutter is when the bird, right, flutters its wing, so that is flutter. So in fibrillation, the heart rate increases, efficiency decreases. In flutter, there is practically no push, right? There is no blood which is going. The heart is just fluttering, right? Muscles, they are vibrating. Then mitral prolapse, it is, which can be the mitral regurgitation or the tricuspid regurgitation. First, we see the tricuspid regurgitation. Very easy, tricuspid valve is over here, right? Tricuspid valve is over here. When the right ventricular pressure increases, the right ventricular pressure will try to push the tricuspid valve, right? But tricuspid is not a very strong valve. Tricuspid is relatively weak valve. But if you see, when you see that thing in dissection, you find that yes, there are cauda tendini, but when the right ventricle is trying to push the blood through the tricuspid valve, there is damage to the tricuspid, and that leads to what's called as the tricuspid regurgitation. Regurgitation. That means the blood will actually flow from right ventricle to right atrium, right? Right ventricle to right atrium. Now, Anvitna. So when you ask the question, can it be identified with stethoscope by the sound? Well, there is nothing like that. You just put the stethoscope and you say this is yes. No. What you have to identify is stethoscope is giving you the signals, right? You put the stethoscope, you put it into tricuspid area. In tricuspid area, when you put and you find that there is, say, the principle is, right, we'll deviate from the topic, but doesn't matter, it will matter of 2 minutes. This is when the door opens, there is no sound. There is sound only when the door closes. So lubbed up is what? When the tricuspid and mitral, they close, you get first heart sound. When the aortic and pulmonary close, you get the second heart sound. So it is like first heart sound, second heart sound, first heart sound, second heart sound, right? That's how things go. Okay. Second, if you are into gardening, you take a plastic pipe, right, and start the water. Water goes out, it won't make any sound, right? Because when the water is going out, right, it won't make sound. You press that tube, and what will happen? There would be turbulence, right? So that sound, right? Because water is turbulating, water is moving, and then it is trying to slip into that small gap. That is what is called as the murmur. It is called as the MUR, murmur. Right. What you have to identify is when the heart is contracting. When the heart is contracting, that means when the ventricles are contracting, are you hearing the murmur at that point? Or you are hearing the murmur when the heart is relaxing. So the point is that there can be systolic murmur and the diastolic murmur. Right? So we'll be understanding this entire thing will come into the form of what is called as the cardiac auscultation. So cardiac auscultation is where there will be a combination of audio and physics, liquid physics, fluid physics, and the audio and the sound. But it is a combination of both. So it makes sense now. See, if this is tricuspid regurgitation, tricuspid valve is unable to hold that fluid, right? So when the right ventricle contracts, that fluid goes into the right atrium, which was not supposed to go. So it is sneaking through that space, so it will make sound. So that's where you'll get the murmur. But this murmur will be soft, right? This murmur will be soft. So you want to hear that murmur. So if you try to hear that murmur from left side, you won't be able to hear it. Right? If you try to hear it from the left side, because this tricuspid area is on the right side. So you have to actually hear. So there will be 4 areas: tricuspid area, mitral area, then you will be having this pulmonary area and the aortic area. Right? So these are the areas: right? Tricuspid and mitral, aortic and pulmonary. So depending upon what you want to hear, you'll be putting your stethoscope. Now in your stethoscope, there would be 2 things. One would be the diaphragm, right? That big one, the normal, right? In movies also they say, right? They put stethoscope anywhere. In one of the movies, so I saw that he put the stethoscope was put on the head, right? So all funny things, right? So so diaphragm is put, right? That is the normal, which we always hold it like this between 2 fingers, right? We are not supposed to touch the patient, right? You are supposed to touch only your stethoscope. Sometimes when you want to hear very subtle sounds, subtle means very delicate sounds, you rotate. And that is what is called as the other side, right? Other side, it is called as the bell of the diaphragm. Bell of the diaphragm. So this is the bell, and this one is the full diaphragm. So that is bell of the stethoscope. I'm planning to buy one instrument, right? That would be a very special instrument, and in which I'll be able to teach you this auscultation at a very senior level, at a very amazing level. Right? It would be a huge system, it will be a complete system, but we'll be able to generate any of the sound, all the sound, and literally you'll be able to diagnose also. Right? I'll let you know very soon about it. Right? Maybe post Diwali, we'll be getting it. Achha, coming back to this, so that is the tricuspid regurgitation. Similarly, this blood, right? Similarly, this pressure, it can even sometimes, it can damage even the mitral regurgitation, mitral valve, which is on the opposite side. But this is more common. And death, right? That can also occur. Because if so many complications they have occurred, and that also, remember, it is not, this patient is not an adult, right? He is just a chota bacha, right? Whose resistance is as such bad, right? So death can also occur. So this would be our prime responsibility, because when this occurs now, first thing, what your patient's parents, they will say, Doctor Saab, bach to jayega. Or the second thing what they say is, okay, you say that this is atrial septal defect, etc. The second question would be, what can be done? And even that is your responsibility. So let's start with the diagnosis. First thing, when you find, like typically when they say this baby is not growing, first thing you'll do is X-ray chest. So here is the X-ray chest. Now you know in X-ray chest, most of the structures you can identify. So this, just by looks, you immediately say that this is a baby. First thing what you see is this heart is big. It is cardiomegaly, right? How to diagnose it? Well, from here, take the maximum width, right? We have learned that. Take the maximum width, and this you say for example, D, and take the maximum width of the chest, right? Let's say this is A. Simply by looking at it, you know that the B, right? This B is definitely bigger than half of A, right? Because heart itself is looking so enlarged. So this is 100% cardiomegaly. So heart is enlarged. We have come to this conclusion. First one, right? Heart is enlarged. Second, when you see the heart, the normal heart looks like quite tubular. Huh? This is how the normal heart looks like. Over here, this is quite flat because this is what? This is the right atrium. From here comes the superior vena cava, right? Here is the superior vena cava. From here, it will be the inferior vena cava. There is so much of bulge. So much of bulge. This bulge is nothing but right atrial enlargement. Correct? The right atrial enlargement. The visual, right? The bulge itself is telling that there is clearly right atrial enlargement. Now over here, we have not yet taken the lateral X-ray. When we take the lateral X-ray, so we'll find that even the right ventricular hypertrophy is there. See, we have used the right atrial enlargement and right ventricular hypertrophy. Those who have not attended the previous lectures, why we use the word enlargement? Because the right atrium and the left atrium, their walls are thin. Their walls are relatively thin. So that's why they enlarge. Ventricles, they have got good muscles. So that's why they hypertrophy. So their walls become thicker. So this is the right ventricular hypertrophy. But this right ventricular hypertrophy, it cannot be said from this. This is X-ray chest, PA view. Right? So it cannot be said from X-ray chest, PA view. It has to be from the lateral view. Lateral view. So this is one important thing. Next is this you need to see. See this. This is pulmonary artery, right? Main pulmonary artery. Pulmonary artery. You don't see this much bulge. See, as we said that this is how it looks like. Right? It's quite flattish. This is so prominent. Literally, without anyone said, we know that yes, there is hump. Right? I remove this line. We see that there is hump. This is called as the pulmonary conus. It is called as the pulmonary conus. See, everything is setting into its place. We said that there would be right atrial enlargement, there would be the right ventricular hypertrophy, and there would be dilatation of the pulmonary artery because of pressure. That is what is called as the pulmonary conus. And this is how it looks like this. Right? That is the pulmonary conus. A very classical thing, right? Which one should never ever miss. I need to zoom this. Focus on this area. When we studied X-ray chest PAV, we said that there is something what is called as the bronchovascular markings, correct? Bronchovascular markings. Those bronchovascular markings should, and in fact, they would never cross the 2/3. They will always be restricted to the 2/3 of the lung tissues, lung surface, and outer 1/3. That would be clear. It is not so that they are not present, but they are so small, so delicate that X-rays they just cannot identify it. Right? There is no difference between the tissues so that they can be identified. But over here, watch what happens. See, these are the bronchovascular markings, correct? All the way, see, all the way going. See over here, so it is going up to this point, right? I'll remove this and now watch, right? If you watch it, it's still more. But it's, see, it should have stopped over here. This is 2/3, right? See all these areas, right? All these. This is pulmonary congestion. This is pulmonary congestion. So we have increased size. See, even at a normal, also you can see that. So I'll write it over here. So if there is increased BVM, right? Broncho-vascular markings. Now in X-ray report, you won't find that it will be telling that bronchovascular markings are seen even on the outer 1/3 of the aspect. No, when it is increased BVM, that itself means that it is seen in outer 1/3. Right over here, for our understanding, we are writing, right, seen in outer 1/3 or peripheral Right? So I'll just put one arrow, right, or two arrows, but you can see that they are seen. So this is the indication of pulmonary congestion. When all these things they are seen, so now you are very clear that this is a case of EST, right? Atrial septal defect. So thus, these are the findings. So these are the findings. Right? This is how things would really look like. Now, if you want to be very sure, now, so this is ASD without Eisenmenger complex. Why did you say that this is without Eisenmenger complex? Because if there is Eisenmenger complex, so then the pulmonary congestion, that load will decrease so that the lung fields, they will become more clear, right? And second, one, the age. Eisenmenger complex takes some time, right? It will not happen immediately after the birth, right? It will take some time. And second, bronchovascular markings, right, they will not be seen peripherally. Seen at periphery. So that's why we said that this is ASD without Eisenmenger complex. Now I show you, this is what is called as the color Doppler. It is called as the color Doppler. Color Doppler, it works on the principle of microphone. We actually, right, when they say that over here, right, when we say we put a probe over here, are kuch nahi, there is no probe. It is a very superb microphone. And it is a very superb microphone. With that microphone, the complete computerized system is there, which will be converting that sound into the image. Right? So it is a combination. It's a combination. What color Doppler works in the principle is what is called as the perceived frequency. I'm just about to explain that. It is called as the perceived frequency. Ultrasonography is slightly different, right? I'll show you. See, this is ultrasonography, right? Ultrasound, which is called as the 2D. But over here, this is Doppler. Now see what Doppler is. This example, right? I'm giving to my students since years, because there cannot be a better example than that. Close your eyes. This is a railway station. Stand, and then that older railway engines, right? That chuk chuk gari, right? And which used to whistle, right? If you are engine driver, if you are sitting in the engine and then blows the whistle, so how will you listen? It will be constant, right? Because you are also moving. Sound is also moving with you, so you will not perceive. There won't be any change. But if you are on the platform, and as the train comes and goes, there would be change, and there will be change in the perceived frequency. So how would it be looking like? As the train is approaching, right, the volume will keep on, the pitch will keep on increasing, right? It will become sharper and sharper, and as the train goes, it will damp, right? So how it will look like? It will rise and then it will fall, right? Because from dur se train and then when it comes in the high volume and then it goes. Bus, this is colored over. So this is the frequency. Frequency is actually the same. The railway engine, right? He is not changing the frequency. It is the same frequency he is releasing. But what we perceive, what we hear, what we feel, that is different. Same thing happens in case of color Doppler. So here it is. The microphone, it is, you are just putting a probe. Right? It looks like ultrasound probe, but basically there is a very sensitive, ultra-sensitive microphone. So that microphone is listening, right? It is listening. Then what sound is coming? As you change the position of that microphone, the sound would change, right? Because now instead of this point, you are listening the train from this point. So yes, right. For this new position, right, it will that sound will be coming from far and it will be coming for more duration. Right? So in other words, the quality of sound will change. So same thing happens over here. In MBBS, in color Doppler, many times when it is shown in training, people make this big mistake. Whenever you see the color Doppler, invariably, whenever there will be the radiology term, invariably this question would ask, right? He will put the probe and he'll say, okay, what do you tell about this red color? And everyone would jump, right? Red color, that means this is oxygenated, okay? And then the probe will change and they'll say, okay, this is deoxygenated when it becomes blue, because this is all digitally generated. Remember, it is never like that. Your microphone, it cannot detect that whether there is oxygen or not. What really happens is, red indicates that blood is coming. Sound is increasing, right? So think it like this. You are over here. You are over here. When the pitch is increasing, so that means this area would be red, right? Sound is increasing, right? It is rising. And when I need to add the blue color. So this is select, right? And when it goes, when it fades, so then that is a blue color, because you know that it is dampening, correct? It is dampening. So in case of color Doppler, when you put the microphone, you'll be able to hear also. So when you hear the sound, visually you see that it is red. Red means wherever the probe is, the blood is coming towards the probe, right? Red means flow is towards the probe or the microphone. And when it becomes blue, the flow is away from mic or the probe, right? Microphone. Probe or microphone. Right? They both are the same. So think it over here. When you are, this is already known. This is left atrium. This is right atrium, right? How to identify, etc. We will see that later, right? But right now, think it like this. The left atrium, this is right atrium, and you are watching it red. From this, what can you make out? The probe is over here. The probe is over here, that means blood is flowing towards this side, right? Blood is flowing towards the probe. So blood is flowing from left atrium to right atrium. left atrium to right atrium. So was it what it is? From left atrium to right atrium, that means we are dealing with AST, correct? It is with AST. Is it with Eisenmenger complex? Is it with Eisenmenger complex? Okay, only one answer. Is it with Eisenmenger complex? AST is there, but is it with Eisenmenger complex? We can attempt thinking. Okay. Two answers, only 2% have answered. Anvit and Durgesh. Okay, Anali, Anand. Okay, now you are answering. Okay, Sally, you said yes. Achha. So if it is with the Eisenmenger complex, what would be the direction of flow? What would be the direction of flow? Eisenmenger complex tells that the direction of the flow is from right to left, correct? From right to left, correct? When it is right to left, and if you are doing the color Doppler, what would happen in this picture? What change will happen in this picture? What change would happen? Or what change can you expect in this picture if it is AST with Eisenmenger complex? Exactly. It would be, yes, that's right. That's right. Atrium is enlarged red. Probe position will, we are keeping the probe position same. We are not changing the probe position. Yes, it will turn blue, right? All of you, those will say blue, very right. Because now blood is going into this direction. It is going from right atrium to left atrium. When it is going from right atrium to left atrium, it means it is going away. That means the whole thing will turn blue, right? It will turn blue. So if it is blue, we say it is Eisenmenger complex. Good? Clear? Any doubt in this? Because so simple, right? AST is there, right? AST is there. Blood is flowing. You are getting it red. Watch where the probe is. Probe is always where the narrow end is there. This narrow end. Right? So sometimes if the picture is ulta, doesn't matter wherever the narrow end, because it always goes like this. Right? So if it is red, just watch which direction the blood, and then you see it, and then you diagnose. Very simple principle. Next, now we see something more. The whole thing will be blue. Exactly. The whole thing will be blue. Wherever the red color is there, wherever the red color is there, it will be blue. Because the direction will be in the reverse direction. Correct? You're right. Now, this one. This is actually ultrasound. Right? So, I think someone asked this question. But this is the difference. This is where you are using pure ultrasonic waves. Ultrasonic waves means our range. What we can hear is 20 hertz to 20 kilohertz. This is the audible frequency, audible range. The frequencies which our ears can hear. That's why sometimes when you go for those earphones, right? Earphones or headphones, good quality headphones. So then they say they'll be covering the entire range from 20 hertz to 20 kilohertz. Which one? Which blue parts? These extra, they are tissues. They are tissues. Okay. So coming back to this, so 20 hertz to 20 kilohertz is the audible range. When you go beyond this, you can't hear those sounds. That's why the words sharpest dogs, Dobermans, right? Doberman. Which one? No, no, nothing, nothing. Don't worry about it. They are just the turbulence of the blood. So sometimes you need to see the main, some minor those things. So coming back to this, the Dobermans, those Dobermans, they can hear up to 35 kilohertz. That's why in the police department or in the narcotics, right, they train certain dogs. You must have seen those dogs at the airport. Right? They are controlled by a silent whistle. Normally, Doberman, right, they won't attack. But the moment that whistle is blown, because that particular whistle, which will be having a specific frequency, dogs are trained for that, they will straight away attack whosoever is in front of them. Right? So there, if you really want to see that how they are trained, there is a wonderful movie. It is called as the Doberman Gang. Doberman Gang, where the 6 Dobermans, they were trained and they do a bank robbery. Amazing movie. Right? Very intellectual, very amazing movie. Must watch whenever you get time. Okay, so this is where we are using those ultrasonic frequency. So that's why when you are doing this, you won't hear any sound. Right? Everything is silent. But as such, high frequency sounds, they are injected and then they bounce back. The principle of bat, right? Chamgada, bat. So those bats, they work on the principle of ultrasonic. They send the waves and then they hit back and then they come, they receive, and that's how they perceive that what's the distance. Over here, this is the probe. Here is the probe who is generating that sound, and that probe sends the waves, and then when they are received by Fourier analysis, this image is generated. So what you are watching is the anatomical structure. You are watching the anatomical structure. You are not watching the blood. You are not watching the blood because blood is liquid. That liquid is having same consistency. So there won't be any change in the sound waves, right? It will be the same sound wave which is liquid. But over here, when it comes to the wall, then wall will be bouncing it strongly. So that's why we get white. If there is no reflection, so we are getting it black. So that's why all the tough structures, they are seen white. Now see, this is right atrium, this is left atrium, this is right ventricle, this is left ventricle, right? So far, all good. See how nicely this powerful mitral valve is seen, because these are the leaflets, these are the cusps, right? These are the cusps of mitral valve. They are called as the cusps of mitral valve. Over here, a very light shadow is seen. It is not so that the tricuspid is that weak, but what really happens is that sometimes the angle, so you might have to change the probe slightly to see so that they come exactly at the level. So, but this is the tricuspid, right? Tricuspid. This is septum primum. And see, only this much is the septum secundum. This is septum secundum. And see, nothing is here. This is a huge AST. This is a huge AST, right? This septum primum and septum secundum. So that is the interatrial septum, right? So this one is the huge AST. What type of ASD is this? What type of ASD? What type of ASD? Good, Shara. That's right. Only one answer. Most common one, but which one? Which one? This secundum. That's right. This is the secundum ASD. Most common. You are right. 70% cases. But see, this is huge. So that is 2D echo. Watch this. Normally, you don't see this. This is, say, wait, if it is there, let me show you that first. First we see this, then we'll go for that previous page. This is CT scan. So over, sorry, this one is, this one is CT scan. Watch this. This is a section which is taken. CT scan is computerized tomography. Tomo means to cut. Right? Tomo means to cut. So to understand this, we need to first orient ourselves. Easiest thing, where is spine? Here is the spine. So 100% this is posterior. If this is posterior, then this is anterior. That part is easy, right? Which side is left side, right side? Whenever we talk about CT scan, we have to think it over here, so it is easy. But whenever you see the CT scan, you have to think it like as if you're looking at the patient standing near his feet. Right? Standing near his feet. So this side is left, this side is right, right? And a heart is as such on the left side. So this is. Now we change the orientation. Anteriorly, what do you get? Anteriorly, you get right ventricle. This is the right ventricle. Right, you get right atrium. Posteriorly, right? Posteriorly, you get the left atrium. And on the left side, you get the left ventricle. All good. Correct. This is what? This whole thing. This is interventricular septum. Right now, I will remove this so you can watch it. So beautifully seen. And this is what? Bus. That's it. Right? This is interatrial septum. Bas itna hi. So this is left atrium, this is right atrium, and such big gap. Right? That's right. This is again secondum. Right? There is nothing like secondum primum AST. Right? This is secondum. If it is primum, then it will be over here. Okay. So this is how you look at the structure. So this is, yes, this is secondum AST. Clear? Now, when you are taking the images, right, there is a method by which when you are taking the images, right, when you CT scan is as if you are taking a digital slice of the human body. So then you can actually collect the information only into this particular area, and then you can superimpose all the things, and that is what is called as the reconstruction of image. This is reconstruction. Right? Reconstruction of the images. So in reconstruction, you can actually create like a 3D model. Right? This is like this is in MRI. In MRI, it is the magnetic resonance imaging. So magnetism is used, but basically it is the sectional radiography. So this is the 3D reconstruction. 3D reconstruction. It's a totally computerized process. But yes, you can mark that which area you want, and then the computer will reconstruct, taking it from, because see, it happens like this is the body, and all the slices they are taken, right? And if you say I want to see this structure, so that much information is picked up from everywhere. To go into more technical things, when we say anything which is having a height and the width, so then it is called as the pixel. Right? Pixel is 2D. So this, when we say this square, so this is pixel. When we sometimes say when the network is bad, things are blurred out. So that we say kya photo pixel ho gaya, right? If you take a digital photo and then you zoom, right? So at one point of time, you will find that it is made up of all those squares because it has got only 2 dimensions. When you add a third dimension, right? That is what is called as the voxel. Pixel is picture element, voxel is volume element. So volume element is 3D when you add the third dimension. Now, because this is a round body, you are taking a section, right? And you can take section from at every level. So thus you collect the piece of information and then you recreate it. So thus you can even rotate it, you can watch it. This is done especially, let's say if someone is having tumor, right? So you can take a normal CT or MRI and then you focus on that and then you do the reconstruction. when you do the reconstruction, you will be able to rotate it and see everything that from which angle, right, which is a feeder vessel, this, that, everything can be seen. So this is one of the reconstructed images of AST, where you can see that how actually the atrial septal defect would look like. See how it really looks like. Such a big gap, right? Such a big gap. Here it is, one more, but this one is very high AST, right? See, this is septum primum. There is no septum secundum. Septum secundum failed fully. So that's why I say this is a high AST, right? Septum secundum failed to develop. And this patient would be absolutely fine before birth. The trouble starts only after that. Okay. There is one more thing. We saw the X-ray chest, right? So once again, with same concept, we start watching it. So here it is, huge, right? This, I mean, just by look at it, you can say that this is cardiomegaly, right? Cardiomegaly. Heart is big. This is one. The second thing, as we watch this, definitely there is the right atrial enlargement, right? Right atrium enlarged. So that is there. The third thing which we watch is that this area is called as the hilum. Right? We saw that thing when we discussed respiratory system. Right? So that is called as the hilum. Right? So if you can say that this is pretty prominent, right? Pretty prominent. So this is in fact, it is the pulmonary marking. Right? This is what is called as the pulmonary marking. So these are the pulmonary marking, right? Very prominent. Another thing, see the big one. This is pulmonary conus. Correct. Pulmonary conus. Everything is clear, right? So we are about to say that yes, this looks like a case of AST, and you are not wrong. This is a case of AST. But before we jump into some conclusion, we thought that let's see that this thing in slightly more detail. And when we see this thing, we find that was lung fields, see crystal clear over here, nothing, right? Bronchovascular markings, they are ending only up to this point. Bas, right? Yahan to it is damn clean. No bronchovascular markings. So this is what? So this is where we say that distal lung fields are clean. So what do we make out of it? What do we make out of it? Distal lung fields are clean. I'll just read this so that you can watch it. Everything is there, but see distal lung fields over here, all clean. So this is Eisenmenger complex. This is ASD plus Eisenmenger complex. Correct. It takes some time, right? So by that time, the heart is getting enlarged, and the limit has come, right? So then the backflow starts. So when the backflow starts, the pulmonary congestion actually slightly decreases. So that's where from distal lung fields, they become clear. But now the right atrium and the right ventricle, they have become so big that they are pushing the blood onto the left side, and this is where the reversal of shunt has started. Right, reversal of shunt, and this time this shunt is from right side to left side. And when you see this baby, immediately you'll find that the baby is not pink, the baby is bluish. Right, the cyanosis has started again, depending upon how the condition is, how much severity it is. Right? So that is what really happens. Now, anything if it is there, there has to be a treatment, right? And faster you do it, better it will be. This is the treatment. This is what is called as the Mbbs. Very smart thing. Right? I'll show you later on. I'll show you the surgery also how it is done. But first, understand the principle. There is one big one, right? This is a big one, and then there is one small side. Always, whenever the pressure is more, so this one would be the side of left atrium, this one would be the side of right atrium, because more pressure, right? More pressure. Its name is, it is called as the Mbbs. Septal occluder. To occlude means to stop, to block. Septa means septa, right? And this is the name, Mbbs. There are two types of Mbbs. One is for the AST, second is for the VST. Atrial septal defect means in the ventricular septal defect. The identification is, say this is like US. The identification is that in case of AST, this portion, right, this portion is thin. This portion is thin. Let me fast forward and show you the Mbbs of VST. See, this portion is thick. So one side will be having left ventricle, on other side will be having right ventricle, but this central portion is thick because interventricular septum is thick and interatrial septum is thin. Right? So that's the reason. That's the reason this one is thin, because interatrial septum is thin. Another thing you must have noticed that in case of ventricles, both the sides are big. Right? Both the sides are big. While in this case, right atrial side is smaller, left atrial side is bigger. So this is what is called as the Mbbs. When you implement it, when you install it, this is how it will look like. This is how it will look like. This is nothing but, this is after the procedure. This is post procedure aortography. Whenever you see the word angiography means you are injecting the dye into the artery, right? And then it circulates, and then you take the picture so that you get the entire circulation. This is into the aorta, and you inject the dye. The contrast media, it is called as the contrast media. It is radio opaque, so now you are taking the X-ray. It is called as the contrast media. This side is left atrium, and in left atrium, all this black what you are watching, that is the dye, right? When it is injected, so you watch that, right? From the probe, right? Say this is the left atrium, so that dye is just spread into left atrium. This is our Mbbs. This one, that is our Mbbs. And it has occluded this because this side is the right atrium. Right atrium is clean. right? There is no dye. That means the procedure is successful. Right? The blood flow from left side to right side has been occluded, has been stopped. So this is what is called as the post-procedure aortography, because you are doing it after. If you do it before, then you will find that yes, over here, all the way, all the dyes will be seen because the blood is flowing from left atrium to the right atrium. So I think we stop at this point. We'll be meeting on the day of Diwali. Will the ASD become larger as we age? Well, it would become relatively smaller. It will become relatively smaller. So again, it depends upon where exactly it is. Okay, so we meet day after tomorrow on the day of Diwali, right, and we'll finish this chapter. Right. So wish you all a very happy Diwali. Though we'll be meeting on that day. Right. And thank you. And see you day after tomorrow. All right. Take care. And see you soon.